Do you know what months are the busiest on the labor unit? These ones, the end of summer, early fall, before the holidays months. I'm not going to lie, working on the OB unit in these months was wild, just as much as it was so much fun. But what I saw over and over again was that these busier seasons often meant your providers had less time. Less time to teach you, less time to educate you about pros and cons, and often less time to give you to make your own decisions. I want to make sure that this doesn't happen to you, and it won't once you join me inside of the Your Body, Your Birth class. An online course created by me, a mama, former labor and mom-baby nurse, and CLC. The video and audio inside this class will take you from overwhelmed, worried, and unsure to prepared, informed, and excited, and ready to chase the birth you want, regardless of how busy your provider or that OB unit might be. To get started right now and save 25% for being a podcast listener, head over to thelabormama.com/birth and use the code MAMA25 to join me for as little as $65 today. The link and your coupon code are in the show notes.
Motherhood is all-consuming.
Having babies, nursing, feeling the fear of loving someone that much.
And there's this baby on your chest and boom, your entire life has changed.
It's a privilege of being your child's safest space and watching your heart walk around outside of your body.
The truth is, I can be having the best time being a mum 1 minute, and then the next I'm questioning all my life choices.
I'm Lo Mansfield, your host of the Lo and Behold podcast. Mama of 4 littles, former labor and postpartum RN, CLC, and your new best friend in the messy middle space of all the choices you are making in pregnancy, birth, and motherhood. If there is one thing I know after years of delivering babies at the bedside and then having and now raising those 4 of my own, it is that there is no such thing as a best way to do any of this. And we're leaning into that truth here. With a mix of real life and what the textbook says, expert insights, and practical applications, each week we're making our way towards stories that we participate in, stories that we are honest about, and stories that are ours. This is the Lo and Behold podcast. Welcome back to another episode of Lo and Behold. Today's conversation, gestational diabetes and your pregnancy. I brought on today's guest because I feel like gestational diabetes, often referred to as GDM, gestational diabetes mellitus, that's the acronym for it, is something that often kind of hits you really hard or unexpectedly in pregnancy, but you're still just left going, I have no idea what to do after I get this diagnosis. I'm freaked out. I'm anxious, I'm nervous. And unfortunately, when this happens and when you're feeling that way, the hospital system, it just doesn't always come around you super well. Yes, they're on top of results. They're on top of numbers, making sure that, we're all doing the best we can moving forward post-diagnosis. But I think that you're left feeling pretty alone sometimes with something that is kind of a lot to handle on top of just the regular burden and mental load that already exists when you're pregnant and you're expecting a baby. Today's guest is Sara Alayev. She is a high-risk OB and L&D nurse. She has worked in 2 of New York City's busiest high-risk hospitals in a fast-paced maternal fetal medicine clinic as well. After seeing too many moms around her with GDM, just left really scared, confused, unprepared, like I was just talking about, right? Sara created the platform GDM Nurse. That is her place to change the story for you guys, to flip all this anxiousness and the fear around. So she is here now. She's helping moms handle GDM, balance their blood sugars, of course, but she's also helping moms feel seen and heard so they can walk into their births like a boss. Lots of clarity, less confusion. That is the goal. The conversation that we had today is really laid out as a very practical, what does this mean? How will this impact me? When does this come up in pregnancy? If I'm positive, what does that mean for my birth? What does that mean for me postpartum? What does it mean for my baby? And you'll also find that it's a really good blueprint for you, not just to navigate GDM if you end up having GDM, but also to do it really confidently, to advocate for yourself inside of it, and then to make sure that the story that you have is not just the one that is specifically prescribed to you because you have GDM, but the one that feels good for you too. Hey, Sara, thank you so much for being here with me today.
Hi, Lo. Thank you for having me. I'm so excited.
Yeah, of course. Why don't you go ahead? I kind of introed you already, but just give us more of a personal intro of who you are, why you do what you do, all of that stuff.
Yeah, so my name is Sara. I'm actually a mama of 2 boys, 3 and 2. And I am a labor and delivery nurse. I am a high-risk OB nurse as well. I've been a nurse for over 8 years now, and this is really my magic sauce, working with mamas, but specifically with GDM mamas, gestational diabetes. I really love educating mamas in general, and I had an awesome opportunity to work in maternal fetal medicine, which is a fancy name for the office that you go to for your anatomy scans and any kind of procedures or any kind of high-risk complications in pregnancy. And I've learned so much since I've been there, and I've actually learned that mamas with gestational diabetes have so little access to resources and support and actual like evidence-based guidance. So I brought that to the online space, even though I hate being online.
We were just talking about that.
Yeah, like I didn't even have an Instagram before, but I feel like this is so necessary to really help mamas. And I just enjoy every day just making a difference. So that's a little about me.
Yeah, it's perfect. So did the gestational diabetes thing, is it personal at all? Like, did you have that with either of your pregnancies?
No, I actually did not.
Okay.
But I've always took care of mamas with gestational diabetes because I've worked in 2 of the most busiest hospitals in New York City. And most of our patients are high risk. So it's the bulk of who we take care of. And in MFM, the bulk of the patients coming in have gestational diabetes. So it's like I talk to these mamas all day and my heart really goes out to them.
Mm-hmm. I think that little clarification for if you're listening and maybe it's first baby or you've just never been with the MFM, again, just to let you guys know that MFM, that maternal fetal medicine, is kind of like she said, just where you get sent when you're not that quote unquote normal pregnancy. So anything that kind of moves you outside of normal, especially prenatally, when we know ahead of time, then they might have you see an MFM concurrently with your OBGYN or your CNM, or your midwife, whoever you're seeing. So it's not like some huge, oh my gosh, I have to see an MFM, like that means something's really bad. Like sometimes it is just I don't want to say just because GDM is a thing that's really hard to deal with for a lot of people. But sometimes it is just because, hey, you've stepped outside of the boundaries of normal. So they want to get these extra kind of highly experienced specific eyes on your pregnancy as well. So.
And also it could be for anything, really. We also do a lot of consultations for women trying to get pregnant and they have some kind of issues, whether it's hypertension or they have diabetes or anything, like they come in for consults. And these doctors are really like, they went to school more than an OB, so they are specialized in like fetal complications and sonograms. So like we're doing a lot of like testing as far as anything, like Lo exactly said, like anything that's not in the realm of normal.
Right. And then any of you doing fertility stuff, I'm sure you're going to come across an MFM. I feel like that's where I actually hear the MFM the most, aside from like the work at the bedside where, you know, we're in it with the patient, but also that prenatal fertility stuff. 100%. And then often you might get transferred over then away from your MFM, which is great. Yeah. Yeah.
Because they have to clear you for IVF.
Right.
Yeah.
Okay. Anyways, sorry. Side note for all of you guys, just in case. Well, I feel like sometimes it just gets thrown around like, all right, we're just going to send you to see the MFM. And if that's me and I'm 26 and pregnant with my first baby and you're like, I'm sorry, where am I like, what do you mean this fancier doctor? So I think it's nice to just honestly know the acronym and know what it means a little bit.
Yeah,
so it's helpful.
Because everybody comes across it at some point.
Yeah, I think so too. Yeah. Okay. So we are obviously here today to talk about this gestational diabetes conversation a little bit more. And I think obviously you will agree with that, but this conversation is super valuable, not just because you and I know that, you know, people get this diagnosis and they get left hanging, but also because I think it's one that can feel so scary, fearful, because we test for this early in pregnancy, usually around 28 weeks. We can talk about high risk or when they test earlier as well. So it's not like you're 40 weeks and then we say, oh, you have high blood pressure, let's induce you. Like this is something that can be going on the entire last trimester, potentially even earlier again. And so it's like you have all this time to think about it, deal with it, consider the implications. And so I do think it's a topic that out of, you know, gestational diabetes, preeclampsia, that I know that can come up at any time, but often shows up toward the end. GBS, a lot of those things are end of pregnancy. And this one is actually, if a third of your pregnancy is a little bit consumed or taken up by GDM, that's a big deal. And so I think, as you know, that's why this diagnosis or this positive screening can really kind of start, I think, the ball rolling in terms of how you feel, anxious, all of that stuff, because you have a lot of weeks and nights to lay there and think about the implications. So why don't you talk about what we do, I'm going to say here in the US, because I know it's not exactly the same all over the world, in regards to gestational diabetes, screening moms, what that looks like during pregnancy.
I love this question. I actually just did a live right before we went on because I was like, I have the perfect opportunity to go live. My kids are not home and they're daycare. That's right. But I love this question because I actually got this question like a few times this week as well. And I don't think people know their options, which is really not okay. So there are different options for screening. And like Lo said, we usually screen around 24 to 28 weeks, but sometimes we do screen earlier if you have risk factors like you had GDM before, you have PCOS, you have a high hemoglobin A1C. Any risk factors we will screen earlier, but the 3 options that you do have is the regular glucose test, which everybody knows about, which has the dyes and whatever controversial. The second option is the fresh test, which is actually FDA approved. And
that one.
Yes, it's actually FDA approved and ACOG recognizes it, which is really awesome because it's a great option that it's available in powder form. They have a liquid form, I believe, out or it's coming out, which is really awesome.
They do. My last pregnancy, I did the fresh test to really just test it out and try something new. And there was liquid available then. And that was about a year ago if we're talking present day.
Awesome. So. Yeah. And I just don't know much because a lot of patients don't take it often, but I did look into it a little. And then they actually have the 1 hour and the 3 hour tests available, which is great. They have the 2 hour postpartum test available as well, which is really great. Know that. Because you want to get retested after your baby since you want to make sure that you don't have insulin resistance after birth, because sometimes it can stay, even though we say, it goes away after the placenta is born. So, and the third option you have, which we touched upon in a live too, is to do finger stick paneling, which is basically when you check your blood sugars for 2 weeks, 4 times a day. And this is going to give us a great picture of what's going on when you are about day in and day out. However, a lot of doctors do not like this option because if you kind of cheat the system and you kind of eat healthy, you'll have normal blood sugars and you'll pass, and then we may not screen you appropriately because doctors like a test. Like you do this, you do a blood test. Okay. We know, but it's a great option if you can't tolerate blood draws because you didn't have a few in the 3 hour. You need to get it done 4 times. If you're nauseous from the blood sugar drink, some people throw up, some people have gastric sleeve bypass surgery, so they can't tolerate a lot of sugar and oral drinks in a one sitting. So it's a great option, all 3. And I definitely recommend that you talk to your OB and discuss your options because every option is great for you. It's no wrong, no right one. And I personally did the regular one, but that's me, Yeah. Just know your options.
I like hearing that because I had this convo on my Instagram recently and we were talking about basically, actually, it was just me saying, hey, I want you guys to hear collectively that if you take the drink and you move on with your life, that's okay. And you may be going, what are you talking about, Lo? Why wouldn't I? So there is some controversy about the standard glucose drink that we've been drinking for a long time because it has some ingredients in it that people don't like. There's dyes in it, things like that. And so there are a lot of people who say, hey, why are we putting this crap inside a pregnant body? That's the last thing we should be chugging down. And I get it. There are ingredients in there that you are why would I do this? And you certainly, a lot of people are I would not eat this and drink this on a day-to-day basis or whatever. And so when I was chatting about this in my stories, I was basically though just saying if you want to drink this, want or need or have to, whatever, if you take this drink the one time and then move on, that's okay. You don't have to get really embedded into this kind of controversy or this argument. Because in theory, like your placenta's job is to filter things out. Your body's job is to care for you and to filter things out. Like if you eat really well and really clean and drink really well and really clean, it's not that you shouldn't have options. You should. And Sara just laid out the 3 that are, you know, like approved and recognized, because there are other ones that are not, you know, the jelly beans, the orange juice, stuff like that. Like you're going to probably have a harder time finding a provider who's cool with those, because they're just not like standard. It's hard to regulate truly, like, are we testing you and screening you well? But I want you to hear, like, you have options here, like the fresh test, like she said, is recognized by ACOG. That's what we've done. I've done. My lab recognized it and approved it. It's not covered by insurance, so you'll have to pay a little bit out of pocket to buy those tests. I think mine was like $24 for the 1 hour screen. But ultimately, if you're like, I'm just going to drink the drink, that's all that's available in my area. Like, this is what my provider wants. It's okay. Yeah. This is me just saying that's okay if this doesn't feel like a big deal. And the other little thing I would say is the traditional drink that you drink, you can often get a dye-free version. So if that's really the part of it you don't like, is the dyes that make it orange or pink or red or whatever, I've taken dye-free versions as well. So I've had the regular ones like you talked about. Then my midwife started offering the dye-free ones. And so I took those. And then with my most recent baby, I did the fresh test. So awesome. You can also kind of find some choice even inside of that traditional drink. I just thought of one last thing. Lastly, the fresh test is not different in terms of the sugar load that you're getting. And Sara, you can remind us like what the actual dosage is for the 1 hour and the 3 hour, but you're still getting all that sugar. I think some people think I'm going to take a cleaner one. It won't make me feel nauseous or queasy. The fresh test still hits you. Is it 50 grams for the 1 hour screen?
Yeah.
Yeah. So the fresh test still hits you with 50 grams of sugar. It's just, you know, cleaner in the way that it's being delivered to your body. So just so you kind of understand the difference between the fresh test and that traditional drink.
We still need you.
Does that make sense?
Exactly. Yeah. We still need you to take that sugar in to see how your body responds to the sugar. Right. It's just without the dyes and the preservatives, and it's just cleaner. Exactly.
Yeah. Perfect. Okay. So you mentioned when you were chatting about screening that if you were to be high risk, which it seems like sometimes we don't know that until you're having a subsequent baby, because we're talking about, oh, you're higher risk because you were GDM last time. PCOS, other things can indicate higher risk, you know, even if it's your first baby. So when might they suggest screening earlier on? And are there any other reasons that they might also suggest doing an early gestational diabetes screen?
So they usually would do the screening at the first viable sonogram, because they want, if you have a risk factor, they want to know early on if you have gestational diabetes. So that can be as early as 9 to 12 weeks.
Really? Okay. Yeah. I didn't realize that.
Yeah. So what you said before is when you're struggling with GDM for the rest of your pregnancy, that's
could
really
be the whole thing.
Yeah.
Yeah.
And I actually have a mama in my GDM mama membership now, which I offer. It's a monthly membership. She actually was diagnosed at 12 weeks. So she's been dealing with this, and now she's 32 weeks ish. I don't know when this is going to come out. Hopefully she has a feedback.
Yeah.
She's rooting for that. So I don't know when this is going to come out, but you know, she's been struggling with this for so long. And that's why they need this support, because can you imagine, like, you have all these cravings and you're nauseous and you finally have the ability to eat, and then you're told you can't eat whatever you want. So it's psychologically, mentally draining, especially if you don't have support system really like supporting you and eating healthy with you. It's just really draining. So yeah, it could be as early as that, and reasons could really vary. Again, it could be for having a high, like a pre-diabetic A1C range. It could be like your last baby was big, like 10 pounds. So we want to know if you have GDM. It could be you have PCOS, which is a really common one. It could be any like indication, like, you know, I mean, I'm trying to think offhand right now. I'm blanking.
Do they do it for weight of the mom,
the BMI?
Like BMI or anything? I feel like I had a mom once say, I think they just tested me early because of my size, but is that actually like clinically a reason to screen early?
I don't think so.
That you're aware of?
I would have to double check that on ACOG's recommendations.
Well, it felt weird to me. And so I thought, I think they might have just thrown that at you.
Yeah.
It might not actually be true.
And I've had mamas tell me that they had to take a glucose test like 3-4 times in their pregnancy, which is ridiculous.
Like just after 28 weeks and then again and again?
Yeah.
Like
they would do it
just
early.
to double check?
Yeah, they would do it early, like 9-12 weeks, and they would do it again at 24 weeks, and they would do it again at 32 weeks. And it was just ongoing. And I was just telling the mom, like, you have options. Like, you could have just said, can I do the 2 weeks of paneling instead? And
here's Sarah and I telling you don't have to do that, guys. Okay.
Yeah.
That's I mean, if there's no medical indication at all, that is nuts.
Yeah. And it's something that I keep getting DMs about. And I just find it really frustrating because they don't know. How would they know any better? They're not in this field. They're not medical professionals. And even me and you, like, we might not even know that unless we actually do our own research. And it is online. Like, everyone could look up ACOG, American College of Obstetrics and Gynecology. You can look that up, but unfortunately, which we always chat about in the membership, is that there are guidelines and a lot of doctors don't follow those guidelines, unfortunately. So you have to really start getting familiar with these resources that should be the standard of care.
Yeah. I can link whatever ACOG allows to be out there for free in the show notes too, if you're listening and you want to know, because it is true. The other part is like guidelines change. So for all I know, 5 years from now, if someone's listening to this, they're like, that's not true. Now we screen at 20 weeks. So it does pay off for you, listener, to like do your own research and do a little quick, Google before your screen, or if they suggest something. This is specific to kind of like prenatal appointments and birth, but I always tell my patients my students, when you're at a prenatal appointment, whether it's your 12-week or your 28-week or your 37, I love to say, leave your appointment and ask like, hey, what's going to happen at the next appointment? Like, don't walk out without asking that, so that you could go home and maybe like look into the GBS screen if they say, oh, we're going to do this next week. And you can say, okay, I want to know what you're talking about before I walk in. And that just happens. And so I think that can be valuable. Same with like GDM. If it's like, oh, the screen's coming up in 4 weeks.
Can you tell me about that?
I'm going to do some digging about it. Yeah. And have some knowledge before, in theory, I say yes to it and consent to it, because this is a consent thing as well. So
100%. And you can ask, what are my other options?
Yeah.
Like, do I have to do, and some doctors are not okay with the fresh test, believe it or not. And,
No, I think that's actually pretty normal. I was with midwives who were great about, kind of all of the more natural things, or whatever word you want to use. But I know that's not like universally true across the United States. And so it is very possible that those of you listening could march in there and say, I'm going to do the fresh test, thanks. And then you get some fight about it, or the lab sometimes won't run that. There's like certain labs that will, and they do all the time, but some still say no. And so, you may have to advocate a little bit for that. So the more you know, the better, right? Good thing you're here. Okay. So let's talk about, I'm sure there could be some a little nuance or difference depending on when you are diagnosed with GDM. But let's say you just taken your 1 hour screen, and then if you do not pass that screen, then we do a 3 hour screen. And Sarah's mentioned that a couple of times, there's like a 1 hour and a 3 hour. And after the 3 hour is when then it's like, yes, you do have gestational diabetes. So let's say someone is sitting in that seat and they've been told, or they just got the phone call. What is kind of the what's next for them?
So unfortunately, I love this question, because unfortunately, there is a big gap between the next steps. A lot of them are left in the dark. Like, what do I do next? They have to wait maybe a week or two for their appointment with a diabetic educator or endocrinologist. I mean, I've heard different things. The way it works right now where I work is that they do have to wait like a week or two, because we have so many patients coming in and we have to schedule these patients in. And so a lot of them are very frustrated. They're struggling. And a lot of them that I'm really proud to say, they do their own research and they find me, which is awesome, because I've had a mama in the membership that she found out she was diagnosed. She was going away for the weekend and she had an MFM appointment like Tuesday or something. Like, she found out like maybe Thursday. She's going to have an appointment on Tuesday. She found me online. She joined the membership, watched all the calls, got all the handouts, and by her appointment by Tuesday, she knew everything walking in. And her blood sugar, like, she already was taking her blood sugar, like, she was already on the right track. And they were really impressed, and they just like spent like 5 minutes with her. So
Awesome.
that's like the best case scenario. However, I hear like people are just really struggling. They don't know what to eat next. They don't know how to check their blood sugar, believe it or not. They're not checking their blood sugar correctly. They just are freaking out. Like, what does this mean? What do I have to do now? Is my baby going to be okay? Am I going to have my dream birth? I mean, a lot of their dreams, they feel go like, and they're, in their mind, they just feel overwhelmed. So that's unfortunately the system that we're in. It's more of a business, and it's more like scheduling patients in.
Right.
So that's where I come in.
Yeah, no, at a practical level. So this mom's sitting there and she will be checking her blood sugars throughout her pregnancy after this diagnosis. So that's like step one, understand that now you're going to be doing, finger sticks to check your sugars until baby is here. And then maybe potentially after, depending on how things go or what happens. So I think even that sometimes can be shocking of, it's not like, oh, I'm just going to eat better. Yes, there are some changes you're going to have to make with your diet, but also you're going to be checking your blood sugars.
4 times
I know you
a
mentioned
day.
like some people don't know how to do it or never have, but I'm sitting here thinking like, if Kelvin got told, my husband, if he got told tomorrow, hey, you have to start checking your blood sugars 4 times a day, he'd be like, I don't know how to do that. Like, what are you talking about as well? So I think for the lay person or whatever vocabulary you want to use there, just even that alone is like, okay, I don't know how to do that. I'm not a nurse or whatever. I don't poke myself 4 times a day. And so even that is just such a like impactful and immediate thing that starts happening. Yeah, so when it comes to diet and nutrition as well, do you feel like patients get separate consults, or it's just kind of like one start off appointment and then their follow up of like, we're going to change your diet, we're going to do these blood sugar checks, and we're going to talk about implications for birth later on? Like, how does that look like for them too?
Yeah, so I can only speak for where I work and my experience. So usually it's a class that they're enrolled into, which it discusses like the basics, like what is GDM and how to check your blood sugars, what to eat, how to count your carbs, all the things that go into it, and your normal blood sugars, what they should be, how you should log it. And they basically tell you that for the next 2 weeks, we're going to try diet and exercise. And then we'll follow up with you in 2 weeks. And if the blood sugars are still high, then we will start medication. That's essentially the gist of it.
And is that pretty normal? Just a 2-week timeline to kind of see how it's going?
It depends. If like your A1C is high or your blood sugars, we tell them like if your blood sugars are, you see like really, really high, like your fastings are like 120s consistently, or like your post meals are like 200 or something. Like we tell them like, please call us. But generally, like if you have no other risk factors, but usually if it's like a patient that had GDM before and they see that their blood sugars are high, they'll call us and tell us like, oh, my blood sugars are high.
Right.
Yeah.
Right. So I guess also the flip side is that is I think that some people can say 2 weeks to figure this out before medication. Like, what's the rush? But I think that actually you can just answer that. There's implications, right, to a baby who's, let's say, like getting too much sugar at a really basic level. And so I think that's why if you're 28-ish weeks when you get your diagnosis, maybe 29 if you did it late, and then it's a couple of weeks of figuring this out, maybe it took you a week to get in front of someone or into the class or whatever, then we're talking, you're 33 weeks, 34 weeks. So we do want to get a handle on that quickly so we can kind of help mitigate possible implications of that. Yeah.
I love that, because I actually told that to a mama yesterday. She was just so confused, like why were we keep checking up on her? And I told her it's not like when you have diabetes outside of pregnancy. When you have diabetes outside of pregnancy, you meet with your endo or your endocrinologist or your PCP like every 3 months. You check your A1C maybe every 3 months. They talk about your diet. Maybe they do it once a year even. It depends on your situation. And then you just move on with your life, and they just give you a medication and whatever. Here, there's a baby involved. And with a baby, we're worried about a lot of complications that can happen if your baby is exposed to high blood sugar. I mean, it's a list, like, I mean, Lo knows all of this, but like, I'm sure she's talked about it too. Like, big babies, which can cause shoulder dystocia, which babies' shoulders are stuck when you're pushing, which is an emergency. That is not fun for us. We don't want any damage to babies. It can cause implications like possibly, God forbid, stillbirth if your baby is exposed to high blood sugars. It can cause baby to be big and your amniotic fluid is high, which causes other complications. It can cause complications for the mother. It can cause preeclampsia. I mean, it's just really harmful for us not to keep a watchful eye on you. Like, people are like, oh my gosh, like, you guys are just like really on top of me. And it's just really because we want the best for you and your baby. And we can't have you walking around those high blood sugars. Like, I tell them, like, 1 or 2 high blood sugars is fine. But if it's consistent, it affects your baby tremendously. And your baby's exposed to high levels of blood sugar, and then they start producing high levels of insulin. And then when baby's born and they cut the cord, baby's blood sugar drops. And because there's so much insulin in this baby's body, and if baby can't transition normally and stabilize it, baby can go to the NICU, and it's just really harmful in every kind of way. So that's why we are so strict with our parameters. Like, people say, why does my fasting have to be less than 95? Why does my meals have to be less than 140? And it's because of the research that we found, based on ACOG again, that high levels of blood sugar can cause a lot of complications.
Yeah, that's perfect. I think sometimes we want to shy away from like the the implications, side effects conversation, right? Because it can sound really scary, or sometimes it feels like we're stepping into those waters of, look at all this bad stuff that can happen if you don't listen, but it's just the reality, right? Like, high blood sugar in the maternal body has a lot of possible implications. And like we were saying, the timeline here is short. It's not this lifelong diabetes that, other people may be dealing with. And so we want to get on top of it really quickly, because we have 8-10 weeks maybe to stay on top of it. And it could be a shorter time frame if induction becomes indicated or something. So it's like we have a few weeks, a couple months to try and do the best we can with what we know right now, and have this be, the best circumstance inside of the fact that now there's gestational diabetes on board in that pregnancy. So I think it's valuable to hear that, because my guess is, and I didn't say this either when we started, but I didn't have GDM with any of my 4 pregnancies. And so this isn't personal for me, but I can picture myself thinking like, everyone just chill for a second. Like, I'm getting this figured out. And I imagine sometimes it doesn't feel like there's a lot of chill coming from the other direction, but I do think it's because it's like, we've got 8 weeks to try and get this at the best place it can be, or whatever. Yeah. And so I guess I just like wanted you guys to hear that as well. If you're feeling a little bit of like, everybody calm down, you're making me anxious type thing, we're trying to do this and turn this around, or get it at a good, as healthy as it can be level as soon as we can. So
100%.
Okay, my own thoughts just led me to my next question, which is the induction conversation. So we've addressed, hey, you could have GDM. Hey, here's what might happen when you do. Hey, you could end up on medication if diet and exercise alone is not controlling your sugars. And then you're going to hit a point where there's going to be an induction conversation. I'm assuming this conversation will come up for everyone with GDM. You can correct me if I'm wrong.
Yes.
So
it comes up for regular healthy women.
True. So of course it's going to come up for GDM. So when do you feel like that comes up? What does ACOG say about when they feel like you should be induced, if you should, what your optionality is inside of that?
Yeah, I love this question, because ACOG says one thing, doctors say another, right? So really, it's a case-by-case situation. If a mother has uncontrolled diabetes, like meaning her blood sugars are high, or baby is big, the fluid is high, that means that MFM will determine your delivery date earlier. Okay, because we're looking at the whole picture. Are
you saying, sorry, that they like will move your EDD, the due date up?
No, not your due date.
Or what do you mean? Or your delivery date,
delivery.
Like when they want your baby delivered by, you're saying, it's going to move up.
Sorry. Okay. Meaning like, let's say like 37 weeks or 38 weeks, right? Just like a mother who has preeclampsia. If a mother has preeclampsia, they'll say, okay, you'll be delivered even sometimes we saw like 35 weeks, right? So it's really case by case situation. Now, having said that, if your blood sugars are normal and your diet control technically, and your baby's growth is normal and there's no like high fluid, polyhydramnios, technically ACOG says 40 weeks.
Okay.
Okay. But a lot of doctors.
But they do recommend induction by 40 weeks. You can go to 40, but no, they don't recommend beyond. Yeah.
Yes. But a lot of doctors don't go by that again. And I have this conversation all the time in the membership because I break down like what happens if you don't want to have an induction and what your options are for that. Now, as far as diet medication, like if you're taking medication, they do recommend, ACOG recommends delivery by 39 and 5, I believe. Correct me if I'm wrong, which is really interesting. Probably like around 39. I would say 39 to 39 and 5 days. And that's really interesting because most mamas taking medication, again, are usually delivered earlier. I'm sure you know that, Lo. But again, it's probably because they're looking at the whole picture, meaning your blood sugars and your baby's growth again, and your NSTs. So if your NSTs, your non-stress tests are non-reactive, like we look at so much. So it's not like a rule. They can write the standard, but it should be a case-by-case situation because your baby might be doing well, but another mom's baby might not be doing well on the NST or whatever. Now, I talk about like how to navigate those conversations with your provider. So first of all, it can come really early. Like sometimes they can even tell you like as maybe 34, 35 weeks. MFM might tell you like, oh, we're going to recommend delivery by X, Y, and Z, 38 weeks, whatever. It can come early. So I definitely recommend you talk to your provider and ask them, what is your policy about inductions with GDM? If they tell you, oh, everybody has to be induced with diet control by 39 weeks, I mean, there's your answer. Right. And you can do with that information what you want. And you should ask them more questions. If you don't want to get induced, can I do non-stress tests and biophysical profiles until I deliver? If your blood sugars are normal and your baby's heart rate is perfect on the monitor and your growth is normal, baby's fluid is normal, baby is growing appropriately, I mean, technically your baby's getting 100 on all the tests. So it is reassuring, meaning there's no like issue like right now that's critical for you to be delivered at this moment. So technically, if you wanted to explore that option, you can. It's really hard because some providers just don't feel comfortable with mamas with GDM continuing their pregnancy past a certain point, especially if they're taking insulin. I mean, this is something that is really talked about a lot in the membership as well. And the DMs that I get, I mean, people are just freaking out because, oh, I'm taking insulin, I have to be induced. Again, it's a conversation to have with your provider. I mean, if your blood sugars are normal, again, and you feel comfortable and you feel baby moving, that's another thing. Sometimes if you're not feeling baby move, we're concerned. So we need all these things checked off, but some providers are just not comfortable. And you have to know that because you need to know how to plan that out.
Yeah. So basically, you guys, what I want you to hear is it's really a case-by-case basis. It sounds like pretty standardly everyone is going to be delivered or induced by 40 weeks. Of course, there's still choice in that. I'm sure some people say, no, I'll do NSTs and BPPs. I'm still not. But like inside of that, like Sarah's saying, like if your sugars are great, if your baby's doing great, like there's this flexibility here that is available to you, but your provider may not always present to you. So just to hear that and know that, I think is really important because you might not get that from your provider to you, but it is real. It is true. It is there. So you had mentioned insulin, and I just wanted to circle back on that really quick. I feel like I always do this, like, tell me really practically, because I want moms to know, like, not exactly what will happen. No one can know exactly what will happen. But you had mentioned if diet and stuff isn't working in those first couple of weeks, then we switch to medication. Is it always straight to insulin? Because I know there's oral meds as well. So it's not always this immediate jump to insulin, correct?
Correct.
We could do orals. If that's not working, then we move to insulin. So there's this whole kind of spectrum that we move across as we're trying to control your sugars, correct?
So a few years ago when I first started as labor and delivery nurse, everyone was on glyburide. I don't know if you remember that, Lo. Honestly, they found so much evidence that glyburide causes neonatal low blood sugars. So they stopped. It was not. I remember running around like a chicken without a head, checking all these babies' blood sugars, taking them
after
to the
birth.
NICU. It was just horrible. And after they did research, they found in general, glyburide causes low blood sugars to anyone. So it's not the standard drug for anyone anymore, but it's still out there. Now, the other option that most doctors are recommending is either metformin and insulin. However, there's a lot of controversy about metformin. They are prescribing it, but it does cross the placenta. So there's that. I mean, there's not a lot of studies with pregnant women. Let's just be honest. So they're not really testing medications with women. And a couple of years ago, when I first started, metformin was contraindicated in pregnancy. I don't know if you remember that. Like if someone was on metformin before pregnancy and they got pregnant, we would switch them. But now it's the standard. Okay, so just so you know, it does cause a lot of like GI upset in general, like anyone taking metformin. And there is a cap to metformin. So the cap is 1,000 milligrams. Some mamas need more medication after, and we can't give more. So there are mamas who are on metformin and insulin, which at that point, it's like, what's the point of that?
Yeah.
So a lot of providers feel more comfortable with insulin, especially like the old school doctors, because you can control it. So you can titrate it, meaning you can increase it.
For sure.
You can give it before meals. You can, give the different types of insulin, but a lot of doctors don't like it also because it causes low blood sugar, and they just don't want their patients to be like struggling with increasing it or lowering it or whatever. And patients are scared of insulin. They're scared of injecting themselves with insulin.
Yeah.
They don't know how to do it. They don't want to do it. They just rather take a pill. So just know your options. You have 2 options, and you can make a decision that what's best for you and your baby.
Yeah. And then insulin, I would add to, in labor, then if you need to be on insulin drip and the fluids and just balancing all that. This is not your concern, right? But it just changes the labor a little bit. So it adds another layer to your labor, right? Because then you're going to continue to need it throughout your labor and delivery. So
you might not.
The insulin?
Yeah, you might not, because the protocols, I mean, every hospital is different. Like where I work, that's usually like type 1 or type 2s if they needed insulin.
Yeah.
But the mamas who have GDM, gestational diabetes, and they're taking insulin, we check their blood sugar, depending on your hospital, every 2 to 3 hours. And we only start insulin if your blood sugar is 120 and higher. That's like a whole new policy that we have now. And it's very rare for mama with gestational diabetes to be on an insulin drip.
Okay. I didn't realize that. So even if they're using insulin throughout the pregnancy to treat, well, are you continuing to dose them then during labor though? You're just saying they're not on a drip?
They're not on a drip. We just check their blood sugar, and we just change the line. So meaning the IV line. So we either give them normal saline, which is no sugar, or if their blood sugar is low, we will give them a normal saline with with glucose, like D5. So we'll keep switching the lines depending on your blood sugar. But most mamas are not on insulin during labor. It's only if you have uncontrolled blood sugars, meaning like it's really, really high, or you have type 1 or type 2 diabetes.
Right. Okay. Perfect. Thank you.
Yeah.
Okay. So induction, definitely going to be on the table. You've got to decide what to do with that, and honestly how to navigate those combos, but you do have options. Post-birth, you've mentioned a little bit, and I just want to touch on this because I think that's the last little bit for this kind of whole spectrum. How might it go?
Yeah.
One thing you mentioned already is that the thought is when the placenta leaves the body, your GDM's kind of just gone. But I know that you could speak to that a little more. And then the other thing is kind of baby could struggle with some low blood sugars while they kind of regulate to being outside of your body and managing, their own sugars and insulin on their own. So do you want to speak to both of those a little bit, kind of what it means for you post-birth, and then a little bit of baby care implications post-birth?
Yeah. Let's start with, I guess, baby.
Do it.
Okay.
Go for it.
Awesome. So when you're in labor, we will check your blood sugars, like I said, every 2 to 3 hours, depending on your hospital. Sometimes it's even every hour, depending on the protocol. After you deliver and you have gestational diabetes, we stop checking your blood sugars. So that we only check it if you have type 1 or type 2, or like you had crazy blood sugars and we don't know where you fit in the spectrum. We'll check it then. But otherwise, so technically you are done, and everyone gets really excited about that, and they just order pizza and whatever after they deliver, which is awesome. You get to enjoy, right? But let's chat about baby first. Like I said, so after baby's born, we will start checking baby's blood sugars after 1 hour of birth.
Mm-hmm.
And so that 1 hour, that golden hour, we really recommend doing skin to skin, which I know you always talk about, Lo. So you guys should check out all her info on that also. But skin to skin and just really promoting that bonding, which helps regulate their blood sugar and their respiratory rate and their heart rate. And we also want you to start breastfeeding and latching baby and really giving that baby some colostrum, because colostrum will help their blood sugars regulate as well, which is beautiful. So we will check it 1 hour after birth, and every hospital has different policies. So sometimes they'll check it like every hour for 3 hours, and if all of them are normal, they'll check it every like in 6 hours or in 9 hours and 24 hours. I mean, every hospital is different. Like I said, I'm only speaking from the hospitals that I worked at. And if the baby's blood sugar is less than 45, that's considered low. So what we will do is we actually have glucose gel, which is really awesome. And it's basically like a vial, a tube of sugar. And we put it in the baby's cheek, and that will help the baby's blood sugar come back up. And we will help you latch. We will want you to breastfeed baby, and then we'll recheck it. And every hospital has different protocols as far as rechecking it and notifying the provider and whatever. If baby's blood sugars are consistently low, and / if their blood sugar is just really low, like if we check it the 1 hour and it's super low, and then we obviously have to recheck it again as a nurse. We know that. Yeah. So you check it and it's low, we check it again and it's low. If it's critically low, we would have to take the baby straight to NICU, because anyone's blood sugar affects your brain, and it could cause neurological complications, and babies can't talk. So we got to move fast to save this baby's life. And even an adult, like if an adult's blood sugar drops, they might not be able to respond. They might not be able to talk. They may faint. Yeah. So it's really important for nurses to be on high guard and to assess the baby really quickly for any signs of like lethargic, like when they're really tired, they're breathing really fast, and, other signs. So that's baby. Now, most babies do really well if you control your blood sugars, but there are exceptions to the rule, especially if your baby is super big or super small. Sometimes, even if you don't have GDM and baby's super small, sometimes they just can't regulate their blood sugar because they're, preterm or they're super small or whatever. So it can happen. And in that case, baby goes to the NICU to be stabilized. And usually it's not something that's like life-threatening after they stabilize baby, but it really impacts the bonding between the mom and the baby, and it's kind of scary. I mean, I don't know if you ever had a baby go to the NICU, but I did, not for this, but for high Billy, and it was just really traumatizing. So I don't want that for anyone, and that's why I always talk about baby's blood sugars as well. So just know like what happens, what the protocol is, and you can even start collecting colostrum in pregnancy. Like if you're low risk, you're cleared for pelvic, you don't have to be on pelvic rest. You can start collecting that closer to delivery. Like if you have an induction scheduled or you're like closer to term, you can start collecting that. Obviously stop if you start contracting. And if you have a history of preterm labor, please do not do that, or short cervix or anything like that. But you could bring that with you and give that baby some colostrum as well to help you really navigate that time frame. As far as the mother, so we stop checking her blood sugars, and then we kind of tell you can do whatever you want, you can go home and eat whatever, right? That's not necessarily true. When you have gestational diabetes, your chances of getting diabetes type 2 in life are, I think I heard the research say that by the time your baby is 5, your chances of getting type 2 diabetes are 50%, which is really scary, because I don't think anyone says that straight up.
No. I think it's always just like I didn't know the numbers. I just know if you have GDM, your risk of type 2 is higher. But that's pretty significant of a number for sure.
Especially if you have consecutive pregnancies with GDM.
Right.
And you're not checking your A1C in between, and you're not implementing the healthy lifestyle choices, and you're just doing whatever, which I know, I get it. Like postpartum, you kind of lose yourself. And especially if you have like toddlers and other kids, you're not priority anymore, but you should be. Because if you're not taking care of yourself and your blood sugars, you might jeopardize your health. And we want you around for your kids and to teach your kids healthy lifestyle choices. So it's really important that, yes, you can indulge a little more, especially after you push that baby out, you get a push present.
That's right.
Or even a C-section, you get a present, but you should continue to have healthy lifestyle choices and really implement what you learned when you had gestational diabetes, like walk after you eat, exercise, pair your foods, don't just eat carbs, drink a lot of water, really increase your fiber and your healthy fats and your protein and things like that, which are really simple if you think about it, because you've been doing it for a while.
It's basically what all of us should be doing postpartum, actually. I'm listening to that, I'm like, yeah, all of us should eat and drink and care for ourselves that way.
Yeah, exactly. So it's really, you're just doing a good thing for yourself and your family. So I really recommend that you keep doing that postpartum and following up with your primary care, checking your hemoglobin A1C after like 3 months after. You can do that because, again, it's the average of your last 3 months, and following up and doing the postpartum test, like they say, like 6 to 12 weeks after you deliver. So that will really give us a better understanding if your body still has the insulin resistance or not, or if, you got cured of GDM. So that's that.
You just said the postpartum test. You're talking about a blood test, right?
The glucose test.
What are you talking about? Yes. So 6 to 12-ish weeks. I'm assuming a lot of people can do it at their 6-week appointment if they have one of those.
Yeah, you can.
And then 3 months out, a hemoglobin A1C check is a good idea too, you're saying. That's like a separate,
Yeah.
Okay, that's perfect. I think sometimes you do hear you think like, just get this baby out and it's all done. But I think as a parent, definitely hear your baby's going to get some blood glucose checks. Like that is going to happen. Yes, we do it at different times. Our protocols sound like they were similar to the ones you were talking about.
Yeah.
But baby will get some checks. And so sometimes I think parents are like, why are you poking them? But it is part of it. Any sort of diabetes coming in means some diabetes check-ins post-birth for that babe. And then, freedom for you, most likely, but being thoughtful with that freedom because we want to take care of you for the years to follow for sure. So that's great. Okay, I think we can wrap it up there for today. I had other questions, funny. I'm like, I'll just put those aside for now.
I know we could talk all like day about this.
Yeah, I really could. I mean, I just want moms to go in and be like, I heard them talk about this. I know what, like that idea of people saying, I heard your voice in my head or I heard your podcast. It's like, yes, that's what I want for you because it will make your experience better. Even if it's not perfect or whatever, like this kind of stuff, it will make it better. And that's obviously the goal, right?
Yeah.
Okay. So you've mentioned your membership a little bit. Why don't you tell everybody really quickly kind of where they can find you or connect with you if they do want some extra GDM help and they need you?
Yeah, I would love to help anyone who's struggling. You don't have to struggle alone. You can get support. You can find me at Instagram. My handle is Gestational Diabetes Nurse. My name is Sara Alayev. I do have an awesome membership that you guys can come into. It's super low cost. And we have a community of mamas just like you. The mamas are doing exceptionally well, like I said. Side note, one of the mamas, actually, she is the one that was diagnosed early with GDM, and she was on insulin and her blood sugars were low, so she stopped her insulin. Like,
nice.
What? Like, yeah. And
that's awesome.
Yeah, her doctors were so confused because most patients, we increase.
Right. Once you're on, you're on.
Yeah, we keep increasing your insulin, and she's doing, they're all doing exceptionally well. They all have different stories and they're all helping each other. They're all giving each other hacks and tricks. So that's really awesome. We do weekly Zoom calls, we do weekly recipes, and we talk about birth prep, which is really awesome. And I also have a blog that I can give you the link for. And I have a childbirth course specifically for GDM mamas. So that's really awesome. And I would love to connect with anyone who is struggling, has questions. I'm here for you. This is literally giving me so much joy every day, just helping mamas, because as a nurse, this is why we became a nurse. I mean, I didn't become a nurse. I don't know about you, but the money is not worth it.
It's not that good.
It's just really to help women have better pregnancies, but smoother births, healthier babies. This is just what I love. So please connect with me. I would love to help you.
Perfect. We'll put all of that in the show notes. I was going to mention too, I have some resources on antenatal colostrum collection, which Sarah mentioned. So
awesome.
I'll drop those in the show notes for you guys too, because I would put a pin in that, especially if you do have GDM as well. But really all of you can put a pin in that. Okay, last question just for fun. What is one thing in your life that's just sparking a ton of joy and just giving you life?
I love that question. I think I touched on it. Can I give you two?
Yes, I'll let you.
Awesome. My first is my family, my kids. I mean, they just bring me so much joy. And now that they're 3 and 2, it's every day is just like a blast. I mean, we just potty trained my first one. So Is that
a blast?
I mean, it wasn't, but now that he is, it is.
Now
because
it is.
It's so cute. And I'm just really like impressed with how much they know and how much they could chat about. And it's just really bringing me so much joy. And my second one is what I mentioned before, how I'm able to help mamas outside of work that actually want to get help. And that's different because they actually are making the changes and they're telling me like, oh my God, my blood sugar is better. My growth is normal. And I had a beautiful delivery. And that just brings me so much joy.
Perfect. Thanks, Sarah.
Awesome.
Okay. Thank you so much for your time. This was great.
Thank you so much.
Yeah. Bye-bye.
Bye.
Thank you so much for listening to the Lo and Behold podcast. I hope there was something for you in today's episode that made you think, made you laugh, or made you feel seen. For show notes and links to the resources, freebies, or discount codes mentioned in this episode, please head over to loandbeholdpodcast.com. If you aren't following along yet, make sure to tap subscribe or follow in your podcast app so we can keep hanging out together. And if you haven't heard it yet today, you're doing a really good job. A little reminder for you before you go. Opinions shared by guests of this show are their own and do not always reflect those of myself and the Labor Mama platform. Additionally, the information you hear on this podcast or that you receive via any linked resources should not be considered medical advice. Please see our full disclaimer at the link in your show notes.